A 27-year-old woman presents to a GP with dysuria and urinary frequency. She's 22 weeks pregnant. There's no fever and her observations are normal. The abdomen is soft with no flank pain. There are no previous urine culture results for this patient. The question is, what is the most appropriate management? Is it A, advise cranberry juice, B, send a midstream urine and await the results, C, start cefalexin, D, start nitrofurantoin, or E, start trimethoprim? The correct answer for this one is D, starting nitrofurantoin. Nitro is great cover against gram positives and negatives, but particularly against the most common urinary pathogens. It's first line for most UTIs. The mechanism of action is not completely understood, but it involves inhibition of bacterial enzymes involved in DNA, RNA, and cell wall synthesis. The key complication of nitro to be aware of, it should be avoided in the third trimester and also neonates due to the risk of neonatal hemolytic anemia. Now, why are the other options wrong? Starting with A, so advising cranberry juice. The classic cranberry juice is some sort of urinary elixir. The evidence simply isn't strong enough, and NICE specifically state do not recommend over-the-counter cranberry products or urine alkalizing agents. B, then, midstream urine and waiting the results. Great idea, big fan of it. We should absolutely do that for this patient. It will get you some cultures and sensitivities, but unfortunately, this will take at least 2 days. Pregnant bladders aren't known for their patience, and you need to start treatment before the results. A delay in treatment could also lead to worsening infections like pyelonephritis. C, starting cefalexin, reasonable choice. It's second line for UTIs in pregnancy. The mechanism of action is similar to penicillins. It binds to the aptly named penicillin binding proteins. This interrupts peptidoglycan synthesis and causes cell death. Cephalosporins are generally safe in those patients who have penicillin allergies, unless that's penicillin anaphylaxis, in which case you should avoid cephalosporins. And then E, trimethoprim. Once the golden child of UTI management, trimethoprim used to be first line, but due to antimicrobial resistance, it's used much less often. The mechanism of action is that it interferes with folate synthesis, which ultimately leads to cell death in the bacteria. It also interferes with the patient's folate synthesis and is therefore contraindicated in pregnancy, as it will lead to congenital abnormalities, particularly neural tube defects.